This morning, the Finance Committee gathers to discuss an emerging trend in Medicare Advantage, marketing middlemen. Now, there's a long history of rip-off artists in the private sector trying to take advantage of seniors who depend on their flagship health program, Medicare. Since I served as the director of the Oregon Gray Panthers, something like a year or two ago, these unethical salespeople would often sell seniors 10 or 15 separate unnecessary Medigap policies that weren't worth the paper they were written on. Senator Daschle, Senator Hines, Senator Dole, and I came in, and we pretty much drained that swamp. The same thing happened at the start of Medicare Advantage. In fact, I think my colleagues were there. Then Chairman Baucus held a hearing on Medicare marketing because scammers were actually going door to door in the South wearing white coats and stethoscopes around their necks to try to persuade seniors to enroll in these plans. We got a few protections, but it wasn't enough. Last fall, I released a report that detailed some of the most outrageous marketing practices I've seen in Medicare Advantage, like vans parked outside senior centers with Medicare splashed across the side and mailers designed to look like IRS documents. Many members of the committee joined Senator Casey and I in calling on the Centers for Medicare and Medicaid Services to make changes to protect beneficiaries from these slimy tactics. CMS moved quickly. Just yesterday, they rejected more than 300 ads because they were just so friggin' outrageous and misleading. At the time, we also said we're not going to take any victory laps. As seniors experience Medicare's annual open enrollment, that started 72 hours ago, our investigators found that marketing middlemen are the latest set of sleazy private sector scoundrels targeting seniors on Medicare Advantage. Now we've got bad actors again gearing up, this time for the new enrollment period. So let's talk about who these people actually are and why they're such a big deal in Medicare Advantage. They are big private marketing companies, and they get in the middle between seniors and their health care coverage. These big marketing companies jump to get in front of seniors, and they especially want to do it during the annual open enrollment period. And what these middlemen are doing is hijacking personal information from as many seniors as possible, and then they funnel the personal information to the health plans that pay these sleazy marketers the most money. Basically, we're going to describe this as a profit for these companies first, help for seniors and taxpayers last. Now, some seniors' information gets passed multiple times from one money-grubbing hand to another. The marketers will sell seniors' data once. If they can, they'll sell it twice. If they can, they'll sell it as many times as possible. The wheel of deceit, friends, just keeps going round and round, ripping off seniors, ripping off taxpayers. The seniors are the ones left getting badgered by phone, targeted on the internet, stuck with mountains of mail, and ultimately a plan that may not meet their needs. To sum it up, the marketing middlemen have made seniors their product, and they are trying to sell as much of the product as they can. Now, it's also taxpayer dollars that is, in effect, lubricating all this. And these dollars line middlemen's pockets. Insurance experts have told us that marketing costs taxpayers $6 billion in 2022 alone. Put your arms around that. $6 billion taxpayer dollars went to marketing middlemen who may have sold your elderly parents, your grandparents, or your neighbors the wrong plan. It's outrageous. It's a ripoff. It's got to stop. And that's why we've had our investigators launching a further inquiry, because we believe there's additional information with respect to these slimy practices. One other quick issue, and then I want to yield to my friend Senator Crapo. We're also in a related effort to stop what are called ghost networks. Now, a year and a half ago, nobody knew what a ghost network was. But a ghost network is what it sounds like. Somebody buys a mental health insurance policy and they expect they're going to get some services. But after they buy it, after the contract is signed and they actually need it, the ghost network basically has no there there. You can't find a doctor. You can't get information about what hours of service they might keep. There's just nothing to follow up on, and certainly nothing resembling the healthcare services you thought you bought. So our investigators looked at a cross-section of mental health plans across the country. They contacted the providers. They asked if they could get an appointment for a family member. They were able to get an appointment 18% of the time. So more than 80% of the time, their plan actually failed them. Even if a senior could make an appointment with provider and get this, they may be exposed to extra costs if they have to go to a provider out of network. In other words, they paid for something, there wasn't any service, they need some health services, they go out of network, and the person they gave the money to originally sticks them with the second bill. So we got a lot of work to do, and I just want to particularly commend my colleagues, Senator Bennett and Senator Tillis. Like Senator Crapo and I and the Finance Committee, we try to be bipartisan. They've introduced a good bill I'm pleased to be a co-sponsor of, try to make sure that seniors will get more accurate data about these services. And we tell some of those ghosts they're fine to run around on Halloween, but they're not going to be able to rip off seniors the way they've been doing. Last point will be this. Over the years, I've come to believe that one of the pieces of the healthcare puzzle that is not getting enough attention is the role of middlemen. Today, we're looking at marketing middlemen. I'm very appreciative that Senator Crapo has joined me in another effort with Senator Stabenow's support and our colleagues here, and that's going after the PBMs, because there again, you have middlemen. In effect, insurance companies taking, big fees, high salaries, rather than getting that money to patients. Now, as Senator Crapo and I have described, these middlemen are not cut from a cookie cutter. They're not all the same. But I think it's important to be looking in the future at this. I intend to do it. We spend $4 trillion a year on healthcare costs, folks, and we can get more value for those $4 trillion. And one of the areas I'm going to be looking at are these middlemen, and I'm very appreciative of Senator Crapo joining me, not just in today's project, but also in the PBM. Senator Crapo.
Thank you, Mr. Chairman. This hearing comes at a crucial time as millions of Americans evaluate Medicare coverage options during the annual open enrollment period. During this window, seniors and many Americans with disabilities have the opportunity to select a Medicare Advantage or MA plan that best fits their needs. I have long championed Medicare Advantage for its success in leveraging market-driven competition to offer patients access to a wide range of cost-effective coverage choices. The vast majority of our MA plans cover services not available under traditional Medicare, including for dental, vision, and hearing health needs. With consistently high satisfaction rates and low premiums, MA's market dynamism serves as its strength, not as its weakness. That said, the complexity of the healthcare system poses significant challenges for Americans from all walks of life, including those enrolled in MA plans. Seniors need clear, credible, and accurate information to navigate the coverage and service landscape. Fortunately, a variety of resources and tools can help guide Medicare beneficiaries through the decision-making processes this opaque system requires. However, the federal government's Medicare Plan Finder, a decision support tool outlining coverage choices, can prove cumbersome and confusing, often displaying out-of-date or otherwise inaccurate data. As we consider options to ease enrollment, We should assess solutions that improve Plan Finder by integrating more relevant information and enabling more user-friendly navigation. Furthermore, we should examine opportunities to empower effective insurance brokers who serve as key community-based resources and access points, including in the context of MA plan enrollment. Through common sense patient protections and targeted transparency, we can promote a vibrant and competitive broker landscape, assisting seniors while preventing deceptive marketing and other problematic practices. Practical guardrails, however, cannot come at the expense of patient privacy or a functional marketplace. With all policies under review, we have an obligation to consider both confidentiality concerns and administrative burden. I look forward to hearing thoughtful ideas about how to improve the enrollment process by better aligning the incentives and increasing transparency. With common sense, consensus-driven, and market-based solutions, we can ensure broad access for seniors to all of the tools needed to make crucial informed coverage decisions. Thank you very much, Mr. Chairman.
I thank my colleagues. We have called an audible and moved seats here just...
Mr. Chairman, I'm sorry, my coffee attacked the chairman just a moment ago, and so we were moving down to get out of the way, so
I
I'm
thought
sorry.
maybe it was something personal.
I know, actually, we didn't like what you were saying, Senator, so we were, no. No, it was the coffee.
I told my friends, as my father would say, this is not going to be one of the great moments in American history. We have survived it all. Okay, we've got terrific witnesses here. Senator Brown's in attendance, and he and I go way back in terms of fighting for senior rights, and so appreciate his leadership. And he's going to introduce our guest from Ohio.
Thank you very much, Joe Wyden. Thank you, Mr. Craig. Good to see you both. Consider staff. Here's your mic.
Yeah.
Just hit the button that should be green.
Yeah. Pull it up.
It's not working. Embarrass me in front of my home state constituent.
This is not our morning.
Yeah.
Did the coffee get into the
I
microphones?
don't know, it may have.
It's a plot. Thank you, Mr. Chairman. Ms. Regg, good to see you. It's my pleasure to introduce Ms. Christina Regg, who's currently the program director for the renowned Ohio Senior Health Insurance Information Program, so-called OSHIP. OSHIP provides education and counseling to assist older Ohioans in choosing the best and the most affordable health and prescription drug coverage plans for themselves and for their loved ones. Ms. Regg began her career at the Ohio Department of Insurance as an OSHIP training officer, went on to work as a training supervisor and assistant director prior to becoming program director about 2 years ago. She oversees the program's grant funding, operations management, outreach and education efforts, and consumer service and counseling. Under her leadership, OSHIP has received national recognition for the high-quality services it provides to Ohio's nearly 2.5 million Medicare beneficiaries. We're a state of 12 million. The importance of those 2.5 million people and the services you provide are really important. She was selected to serve on the National SHIP Steering Committee from 2012 to 2018. She served as chair for the last 4 years of that period. Ms. Regg, thank you for your commitment to making enrollment easier for Ohio Medicare beneficiaries. Thanks for helping them get better coverage and save money. Thank you for joining this committee today. I look forward to hearing your testimony. Thanks so much.
I thank my colleague, and Ms. Regg, my mother always used to say after basketball games, dear, just make sure tonight you're running with the right crowd. You Ohioans in the right crowd. We're glad you're here. Thank you, Senator Brown. Our next guest will be Kobe Blumenfeld-Gantz. Mr. Blumenfeld-Gantz is CEO and co-founder of Chapter, a technology-enabled Medicare and retirement platform. Previously, he worked at Palantir Technologies, got undergraduate degrees from the Wharton School and the University of Pennsylvania. He holds a master's in public policy from the University of Cambridge. We very much welcome you, sir, and look forward to your comments. And then our final witness will be Krista Hoagland, Chief Executive Officer of Security Health Plan, been there since 2021. Security Health is part of the Marshfield Clinic Health System in Marshfield, Wisconsin. and she is the serves on the executive committee of the board of directors of the Alliance of Community Health Plans, and she's also an actuary. So we thank all of our witnesses. This is an important hearing. We're going to have everybody take 5 minutes for oral testimony. We've got plenty of questions, and Ms. Reed, let's start with you.
Good morning, Chairman Wyden, Ranking Member Crapo, and members of the committee. Thank you for the opportunity to appear before you today. My name is Christina Regg, and it is an honor to be here. I am the Program Director for the Ohio Senior Health Insurance Information Program, or OSHIP, at the Ohio Department of Insurance. We are one of 54 SHIP programs that are funded through a federal grant to provide objective and unbiased information to individuals on Medicare, their family members, and their caregivers. SHIPs provide local and unbiased information to empower the consumer to make an educated and individualized decision regarding their prescription drug and health insurance coverage. 2023 marks my 26th year with OSHIP. So I began as the boots on the ground, traveling Ohio's 88 counties, 29 Appalachian, providing one-on-one counseling about Medicare Part A, Medicare Part B, and at the time, maybe Medigap. This month, our program began counseling Ohio's now 2.5 million Medicare beneficiaries to help them make educated decisions for 2024 coverage. We now operate in a hybrid model, providing information and education both through virtual and in-person events that we advertise through social media, paid and earned media, and grassroots efforts. The information that we present now vastly differs from my early years with OSHIP. Many of the counties that we counsel in, there are more than 100 health plan options for us to review. Most Medicare beneficiaries won't review or change plans because the task of comparing is too daunting. To help narrow the field, we do use Medicare's Plan Finder tool. This web-based tool allows us to determine if their current prescription medications are covered, outline all out-of-pocket costs and plan details, but it does not include the plan network. It rather links to the plan's website. The company websites can be difficult for Medicare beneficiaries to navigate alone. We use that as a launching point. We then ask the consumers to reach out directly to their providers that they are not willing to give up and ask very pointed questions right down to the contract number to make sure they can continue to use those services. Counseling Ohio's low-income and limited health literacy Medicare population brings added challenges. These individuals are more apt to join a plan solely for the added benefits, specifically the over-the-counter allowances and other cash rewards. Many are applying for the extra help or Medicare's assistance with prescription drug costs for the first time. Even when the application is automatic, there are delays, which can lead to affordability issues at the pharmacy window. SHIPs assist by getting them into temporary programs like Lynette to help curb those costs. Also, special enrollment periods for low-income individuals are often misused, putting consumers into managed care plans more frequently than the quarterly allowance. OSHIP's assistance is often reactive in those situations when the beneficiary has found themselves having difficulty receiving needed medical care or prescriptions. In my time with OSHIP, I have seen extreme growth with the Medicare population, growth within the scope of SHIP work, and extreme growth with the plan options. Our Medicare consumers are overwhelmed by the volume of options in each county. They're flooded with marketing material and often confused by the variance of plan details, networks, and these added benefits. The desire to have benefits you're entitled to or added benefits often masks the need to look at critical plan data, such as the specific costs, the networks, and other restrictions they may encounter. This often leads to poor enrollment decisions and undesirable outcomes. Medicare beneficiaries would benefit from additional oversight. A personalized annual notice of change would assist beneficiaries in better understanding changes, such as higher costs from year to year. stronger oversight on the utilization of special election periods, such as the low-income or emergency special election periods, and a block on enrollments for those with cognitive impairments could minimize improper sales to the most vulnerable beneficiaries. Reinstatement of measurable differences when approving plan contracts would help contain the volume of plans in each county. These actions could help make the process of choosing and enrolling into a Medicare health plan less intimidating. I am happy to answer any questions and remain dedicated to this population. Thank you.
Thank you very, very much, and I go way back with your organization, the Oregon chapter, so great to see you. Mr. Blumenfeld.
Chairman Wyden, Ranking Member Crapo, and members of the committee, thank you for inviting me to testify and for dedicating time to this important topic. My name is Kobe Blumenfeld-Gantz, and I'm the CEO and co-founder of Chapter, a technology-enabled Medicare navigation platform. I started Chapter because the Medicare enrollment and navigation process is broken and consumers deserve better. Fighting deception and improving the Medicare experience is personal to me. My parents were the first two people that Chapter helped, and they're the reason I started this company. They needed help fixing mistakes they made following the advice of a broker who had no obligation to prioritize my parents' interests over his own. My parents' experience of confusion and costly mistakes is the norm, not the exception. Choosing the wrong Medicare plan can add thousands of dollars of extra costs for consumers, and it can even make life-saving medications unaffordable. Before I highlight more of the challenges facing Americans on Medicare, I want to share Chapter's unique approach to guidance, which has afforded us insight into what consumers are up against. Chapter is a consumer-first Medicare navigation platform. The breadth of Medicare choices is overwhelming to most, but with good data and tools, choice is empowering. We've invested millions into building a Medicare data and technology stack from the ground up to recommend the right plan tailored to each person's needs. Our exceptional engineers and Medicare advisors are dedicated to demystifying Medicare for every American. But it shouldn't require world-class data scientists to help an American choose their Medicare insurance. We've upended status quo incentive structures in the brokerage model. We consider the full scope of Medicare options from every carrier, and then we recommend the right one, even when we earn no money. We operate this way because no consumer should enroll in a suboptimal Medicare plan simply because their broker earns a commission. Consumers are more likely to wind up on the right Medicare plan when their advisors' incentives are aligned with their own. Every American who enrolls in Medicare deserves to do it with clarity and confidence. I wanted this for my parents, I want it for every person who works with Chapter, and I want it for myself someday. Here's how we get there: better data, ending deceptive marketing, and prioritizing consumers' interests. Consumers deserve significant improvements in the quality and availability of data, specifically on provider networks, benefits, and prescription prices. Without these, consumers, along with the organizations trusted to guide them, will continue to struggle to make informed choices. CMS sponsors some of the tools with the greatest potential to help, like Medicare.gov's Plan Finder and their published data files. These valuable resources are widely used by the industry and by state health programs, but if Americans need support making a fully informed decision, these tools are not enough. For example, Plan Finder cannot help a consumer understand which plans let them keep their doctors, and there are limits to the information on how much a prescription will cost on each plan. Consider a consumer who sees 3 doctors. They might need to compare over 100 separate searches across each insurance company's website. It is not reasonable to expect a typical consumer to conduct this search. Insurance carriers owe it to consumers and to the industry that supports them to provide open, accurate provider network and other benefit data via API. How can we expect consumers to make informed Medicare-related decisions when they lack the data and tooling to do so? Chapter has worked hard to solve this problem for consumers, but it has been an uphill battle. Accessible, transparent data is the first line of defense for any consumer making Medicare decisions among a barrage of misinformation. Last year, this committee published a report on deceptive marketing, and I commend the committee's ongoing focus on this topic. Every fall, Medicare-eligible consumers are bombarded with mailers, TV ads, and phone calls rife with misleading and pernicious content. The bad actors are typically not local brokers who live in each community. Rather, they are lead generators operating as marketing middlemen who traffic in scare tactics, imitate government agencies, and inaccurately advertise plan benefits. CMS proposed regulations to prohibit the transfer of consumers' personal information from one marketing middleman to another. This would have been a welcome change, but these updates were excluded from the final rule this year. At Chapter, we've trained our experts to help consumers distinguish between scam Medicare ads and real government information. But the fact that we have to do this is an indictment of how brazen some Medicare advertising has become. The current Medicare brokerage model is broken because there are no legal requirements for stakeholders to prioritize consumer interests the way we do at Chapter. This hurts consumers, and it hurts the reputation of the Medicare program. Brokers should be held to a higher standard of conduct and accountability. Brokers could be required to consider all plans when making recommendations. Agencies could ensure that their salespeople are not incentivized to push plans that pay higher commissions. If we can commit to transparent data, honest tactics, and putting consumer interests first, we can help Medicare live up to its promise. Thank you for your time, and I look forward to your questions.
Thank you very much, and I want you to know, I took notice particularly of your statement that we missed out this time on the rules with respect to marketing middlemen. That's going to change, and I thank you. Ms. Hoagland.
Chairman Wyden, Ranking Member Crapo, and members of the committee. My name is Krista Hoagland, and I'm the Chief Executive Officer for Security Health Plan, a provider-aligned plan that is part of the Marshfield Clinic Health System. It is my honor to be here today to discuss this important topic of protecting Medicare beneficiaries. Prior to my current role, I served as the Chief Financial Officer and Chief Actuary at Security, with nearly 20 years of actuarial experience, including working on MA bids. And on a personal note, I am familiar with the consumer side as well, as both of my parents are Security MA enrollees. Today, I'm here to share our experience about competition and marketing practices in the Medicare Advantage market. Security Health Plan has offered MA for 2+ decades, proudly serving more than 60,000 beneficiaries today. This year, for the first time, a majority of all Medicare-eligible beneficiaries use MA for their coverage, and it is growing quickly in popularity. CMS estimates next year there will be an additional 2 million more MA enrollees compared to this year. However, in recent years, enrollment growth has not been evenly distributed among plans. In the most recent open enrollment period, 2/3 of national enrollment went to just 2 large national for-profit companies. We very much appreciate the attention this committee and CMS have paid to the issue of inappropriate marketing aimed at seniors, but more must be done. While consumers get information from many sources when choosing a Medicare Advantage plan, the single most influential perspective does remain brokers. We value the important role brokers play in efforts to educate our consumers, sell our products, and support our members. Local brokers are a trusted partner for Security Health Plan and health plans across the country. In fact, 85% of our MA enrollment at Security Health Plan comes from our more than 500 brokers that we are very proud to partner with. Unfortunately, we know some large firms and third-party marketing organizations leverage their influence for financial gain rather than what's in the best interest of the consumer. Many of these field marketing organizations receive add-on or incentive payments that go above and beyond the CMS-approved broker commission caps. Instead of collecting the maximum commission of $611 for a new enrollee, many brokers are collecting $1,300 or more. This additional compensation is marked as marketing, administrative dollars, and can include all kinds of additional add-on fees besides that. This creates an environment in which beneficiaries and ultimately the Medicare program itself are paying out billions in unnecessary dollars. These aggressive marketing techniques have real-world consequences. Just last week, in a conversation with one of our trusted broker partners, he described the ambush that had already begun ahead of open enrollment, which is technically not allowed, with his clients receiving as many as 5 or more phone calls a day. And his team is barely able to keep up with their existing customers, answering their questions, making sure they understand what those calls are about, let alone seek to support new enrollees that might be interested in enrolling in MA. In a previous Medicare open enrollment period, our team assisted a senior who was tricked into enrolling in another plan. We worked with the consumer to re-enroll in the Security Health Plan product not once but 4 times in a single open enrollment period. These aggressive tactics make it more difficult for smaller regional health plans like Security Health Plan to compete. Less competition between MA plans means less pressure to keep costs low and less innovation. This is a disservice to beneficiaries and taxpayers. I urge you to engage with CMS to review the practice of add-on broker payments to ensure that unfair practices are inhibited, especially total payments above and beyond the CMS caps. Further, CMS and regulators must remain vigilant in enforcing marketing rules that protect seniors from misleading and aggressive marketing. 3 immediate changes that can be made to ensure that brokers remain sufficiently compensated for assisting beneficiaries. We're also ensuring that health plans utilize Medicare dollars to compete for enrollment based on benefits and quality are, first of all, standardizing and limiting total compensation. So rather than a commission, a total compensation cap. Thinking about creating incentives for enrolling beneficiaries in high quality and value-based plans. And finally, transparency in requiring total broker and third-party marketing compensation so that we can all understand all the dollars that might be flowing through these mechanisms. Chairman Wyden, Ranking Member Crapo, and members of the committee, again, I'm honored to be here. Creating a well-functioning MA program that protects beneficiaries and supports them in making well-informed decisions is crucial to the long-term success and sustainability of this program. I thank you for the time this morning and welcome the opportunity to answer questions.
Thank you all very much. And this, of course, arrives at such a crucial time, the start of the open enrollment season. Let me start with you, Ms. Hoagland. You gave us an example of what amounts to a jaw-dropping ripoff. You basically said that some of these plans are paying $1,300 or more for a new enrollee. Is it right that when you add all of these extra costs, all of the costs heaped onto the system by these middlemen, this comes to somewhere in the vicinity of $6 billion?
Yeah, I would say that estimate might even be low. Truly, I think it's really important that we're recognizing the amount of dollars that we're talking about here. They are quite significant at the benefits of perhaps lower costs for taxpayers or additional benefits for enrollees. So as I said, that maximum commission of $611 per new enrollee, but we're continuing to see this growing trend in paying these field marketing organizations, these middlemen, as you call them, all kinds of additional fees. You can call technology fees, referral bonuses, marketing, health risk assessment, and on and on and on. The list of creative add-ons continues to grow. And so this has really become sort of an arms race and creating this anti-competitive environment where, to my colleague's point here, that folks aren't necessarily being enrolled in the plan that's right for them. They're being enrolled in the plan where the incentive lies. That's the largest.
And the reality is we want competition in the system based on coverage. I'm thinking my friend and I worked together back in 2009. We had a bipartisan bill, and Senator Stabenow was with us on it as well, that would have put the competition in terms of who would get the best for their health care dollar in terms of coverage and options. And that leads me to my last question for you. The way we stop the ripoffs in traditional Medicare, and I mentioned, when I was director of the Great Panthers, I'd go to a senior's house, and they'd go to the back room and be kind of embarrassed and bring out 10, 15 policies that weren't worth the paper they were written on. They had these fancy subrogation clauses, and you basically got nothing. The way we drained that swamp is we had some core standardized principles around which traditional Medicare is offered. There's competition, but it's competition based on coverage, not who can win the arms race. Is that really what you're recommending here?
Yeah, absolutely. We want what you want, which is sort of fair and equal competition. But competition ultimately is what is best for our seniors, and making decisions based on the benefits offered, right? Not the financial incentives.
So you characterized it as an arms race. Paint the picture of what would happen if nothing is done. Supposing the Congress just says, we're very busy, we don't have time to deal with it, and they're making a good point over there in finance, but we got a lot of stuff on our plate. I share your view. I think there will literally be a healthcare arms race, but paint the picture of what that would look like.
Yeah, I mean, I think the first thing is we would continue to see add-on payments. As I mentioned, there already is a lot of creativity about what these things can be called, and I think we continue to see that number grow and grow if there's no caps or additional transparency, and then ultimately that starts to inhibit competition, as smaller regional plans in particular are not able to afford to keep up in that arms race and continue to make these add-on payments. And so I think that ultimately it does lead to less competition and not things that are in the best interest of the beneficiaries.
Mr. Blumenfeld-Gantz, just a question for you about ghost networks. And, you know, my 10-year-old is always wondering why I'm always talking about ghosts. And, you know, the point really is 6, 8 months ago, nobody knew really what this was about. But this is about as stark a ripoff as I can imagine seeing, because if, say, somebody in the audience or a family member buys a policy that they think will give them essential mental health kind of services, and then they go to get them, they find that nobody is there. There aren't any providers, and you don't get any information and services, and there may not even be a directory in terms of where to go. Why is this so serious? You've looked at this, I know, in considerable detail. Tell the committee why it's so serious.
There are a few aspects here, and it is a really serious issue. I think there are gradients of how this plays out in practice. On the one hand, on the far side, as you're alluding to, there are networks that just don't exist, that are straight fraudulent. That is not legal today. It's an enforcement issue, not a policy issue, because that is not allowed based on the rules. But there's a really complicated gray area in the middle where you have networks that do exist, but there are no open opportunities for patients to schedule appointments for a host of reasons, either because the providers are overbooked and understaffed, or because the tooling isn't sufficient. There are a host of reasons. But I think even from the well-intentioned perspective, when there is good intention, it can still be very challenging for consumers. And so when we look at additional policies or regulations that we could consider, certainly better enforcement of the true ghost networks that just should not exist, and there should be better enforcement there. But I do think there's an issue as well of provider networks that do exist but are just really hard to access.
Great. Senator Crapo.
Thank you, Mr. Chairman. Protecting seniors' privacy should be a top priority during the enrollment process. Because Medicare and Social Security numbers can be used to file false claims or enroll beneficiaries in plans without their consent, federal regulation prohibits marketers, whether calling on behalf of a plan or a third party, from asking beneficiaries for this information. However, a recent survey of seniors over the age of 65 found that 10% of all respondents were asked for their Medicare or Social Security number. Mr. Blumenfeld-Gantz, outside of the formal enrollment process, is there a time when a broker or marketer would need a beneficiary's Medicare or Social Security number?
There should not be.
What are some of the challenges that the federal government faces enforcing the current guidelines, and what additional steps should the administration take to conduct better oversight in order to protect the beneficiary's privacy and to prevent fraud?
Thank you. As I alluded to in my opening statement, there were proposals to make it more difficult for middlemen to sell and transfer data to multiple consumers. And I think that is a really helpful step. That would essentially make it illegal for a middleman to sell the same consumer's data to multiple additional middlemen, multiple third parties at the same time, which is the status quo. It's legal today, and it's what happens today. And that's, I think, one big step we can take. Another big step we can take is making it easier to have more transparent information online. The status quo right now is that it's very simple from a regulatory perspective to provide information over the phone. It is extremely onerous for third parties and good actors, including Chapter, to provide that information online. It's much easier to provide it over the phone based on the regulatory framework, and I think that should be inverted.
All right, thank you. That's helpful. Ms. Hoagland, in your testimony, you stated that one entity alone cannot reasonably educate all current and potential MA beneficiaries about their plan choices. I also agree that brokers play a very important role in helping many seniors navigate their choices to find the plan that best fits their need. You mentioned that brokers are responsible for 85% of social health plans' MA enrollment. Can you expand on your company's partners with brokers to better serve your beneficiaries? How you better partner with brokers to do that?
Yeah, so appreciate the question. As you know, the open enrollment period is a relatively short amount of time, and for a health plan of our size to be able to service all those enrollees that we'd like to in that period of time is just not feasible. So we do believe strongly in partnering, particularly with our local brokers who, again, in most cases, want the same thing we want, which is to put the consumer in the product that's absolutely plan that's best for them. And so we do educational events to make sure that our communities, the brokers in our communities understand what we can offer, how those might compare to other options, and make sure that there's education on an ongoing basis. We also make sure that the regulations are communicated, what's allowed and not allowed in terms of practices. And we're very particular in who we partner with, making sure that, again, that the brokers are aligned with us and making sure that they're committed to following the CMS regulations that are out there around how they interact with our beneficiaries.
So we're very fortunate that your plan is very responsible. And if we could get every plan to do the same, we wouldn't have a lot of the troubles we're talking about here today. How should CMS and Congress balance protecting seniors from fraudulent or abusive actors while also helping plans to ensure that they continue getting the education and support they need to make these decisions?
Yeah, so I'll just say that, we certainly have shared the same concerns with CMS that we're sharing with this committee today, and they have been very interested in understanding and are, I think, committed to helping address this problem in the same way that this committee is. And we certainly think bipartisan support today would be something that would be very valuable in helping them move and take additional steps around addressing areas where there is abuse or misuse. We continue to partner when we have specific examples as well of where someone has not followed the regulations and making sure that CMS has that ongoing awareness so that they are in a position to address it.
All right, thank you very much.
I'm going to go to Senator Stabenow in just 1 second. I also noted, Ms. Hoagland, that you talked about your sense that it is these big plans. You talked about 2 big plans that are the bulk of the problem, and there are a lot of people at the local level, brokers and others who work with you and the like. I'm not going to take more time because this is Senator Stabenow's time, but I'm going to want to follow up with you on that. Thank you. Senator Stabenow.
Well, thank you, Mr. Chairman. Really important question that you just asked. And I want to thank you and our ranking member for holding this very timely hearing, particularly because we are now at the beginning of the annual enrollment period for Medicare. And so I do want to start by just stressing that the good news is that in this enrollment period, 65 million Medicare enrollees, seniors, and people with disabilities will see new savings on prescription drugs, thanks to the successful Democratic efforts about a year ago, such as $35 cap on insulin, which is so important, free vaccines, and an inflation cap on Medicare Part B drugs like cancer treatments that I know the chairman championed, and we appreciate your effort. And we're also seeing Medicare begin the process. The first 10 prescription drugs will be negotiated in terms of lowering price, which is long, long overdue. But at the same time, during this time, why we're here today is that it's critically important that beneficiaries get the coverage that's right for them and that they think they're signing up for, that they think they're paying for, and not get deceived into selecting coverage that doesn't allow them to access the best and most important services that they want and need. I think it's really important also to note that because being involved in this initial discussion about should we open Medicare to Medicare Advantage? Should we, the private sector, for-profit businesses wanted to be a part of Medicare. There was an argument around lowering costs or providing more benefits. We now are paying 4% higher rates for Medicare Advantage than what is paid for under traditional Medicare. And that makes it even more concerning that we're seeing $6 billion in taxpayers' funds being used to pay for marketing middlemen, or Ms. Hoagland, as you said, it may be more, actually. We don't know for sure on this, but it's even more concerning, given the fact that Medicare Advantage is already receiving a bonus to participate and be a part of the Medicare system. I'm particularly concerned about situations, as my colleagues have said, where people are seeking out particular benefits, special benefits, dental, vision, hearing, other additional behavioral health services, and then they find out if they sign up that they really aren't getting the care that they need. And I wanted to speak specifically about it and ask a question about mental health, Ms. Reeg, because 1 out of 4 Medicare recipients, as we know, have a behavioral health condition, either a mental health issue or addiction issue. And many of them aren't able to get the care that they need. That's been a particular focus of mine for a long time. But we know that there are so many barriers put up under Medicare Advantage plans, and we heard about those today, prior authorizations, required referrals, and so on. I remember discussing when we did the Affordable Care Act and offering the amendment to make sure that we had parity, that you couldn't do that under, and yet it's still happening. And now we have President Biden coming out with additional rules they want to enforce on this whole question. But these things are still happening, particularly through Medicare Advantage. So when you're counseling someone to find the best plan for them, how do you help them understand those barriers? How do you find out about the barriers, particularly when it comes to mental health care?
It involves that individual conversation and really getting to know our community and the individuals that we're serving. With regards to mental health, I think you spoke accurately on the need to know the network and making sure that there is availability prior to signing up for the plan. Additionally, where a lot of consumers miss the education piece is knowing if there's a prior authorization situation where they have to have a relationship with their primary care physician as a gatekeeper to that specialty care. And those are things that the SHIPs can help assist. In Ohio, our SHIP physically sits at the Department of Insurance. We're very fortunate that we're also home to the Mental Health Insurance Assistance Office, and we can collaborate to make sure that we've extended additional education to those consumers.
Thank you. I would just say that I still am so concerned, in general, when we look at mental health or addiction services, somehow special care, rather than just the continuum of healthcare. Healthcare above the neck should be treated the same as healthcare below the neck. It should be healthcare. And so we start with barriers for people. And so I think at this point, my time is up, Mr. Chairman, but thank you very much.
And well said by my colleague, who is the point person in the United States Senate for Advocacy for Mental Health, and we appreciate her comments. Senator Cortez Masto is next.
Thank you. Thank you, Mr. Chairman, to the ranking member and all the panelists today for this important conversation. I have to say, in Nevada, as of October of this year, roughly 50% of Nevadans eligible for Medicare are enrolled in an MA plan. This is such an important issue for my state. And as we're hearing, of course, we need to better leverage transparency tools across Medicaid programs, including Medicare Advantage. With the enrollment, as we're hearing, and spending growing, I am actually working on legislation that will help policymakers and researchers assess the value of these plans deliver to over 30 million Americans. For today's hearing, though, I do want to focus a little bit on the importance of transparency for consumers. So, Ms. Reeg, I have heard from Nevadans, including in staff in my own state, in my own office, who are trying to help their parents. And they are trying to enroll in Medicare coverage for the first time. They meet with a broker or see an advertisement about Medicare Advantage plans offering $0 premiums and boundless supplemental benefits. Sounds good, sometimes too good to be true. Are advertisements like this misleading? And if they are, what should federal government, what should we be doing about it?
They are, and this has gone on for years. On all of our public presentations and our counseling, we beg the consumers, do not choose your health, your prescription drug coverage based on an advertisement. The advertisements will focus on the zero premium, zero copay at a primary care, maybe no copay for generic medication. But we really want them to look at things like, what is the copay for inpatient hospitalization per day? And when it comes to Medicare Advantage, also know that maximum out-of-pocket, which would be a limit to their financial risk. So the advertisements over the years have gotten more aggressive, and they do focus on those added benefits, specifically cash allowances, debit cards, money to go into the local drugstore and purchase items that aren't covered. And we have counseled numerous individuals, especially over the past open enrollment year. They were very upset with us because we could not use Medicare's Plan Finder tool to order the plans in order of the highest debit card to the lowest. And when we try to circle back to things like their specific providers, mental health needs, and other critically needed services, they really want to focus on those added benefits. And that has been a challenge for us due to the advertisements.
So is there, and I understand the federal government's recent steps to curb deceptive marketing help seniors sign up for Medicare coverage. Is that helping? Could you see some of that?
We are cautiously optimistic. We'll know more as plans go into effect in 2024. Personally, I've seen a bit of a difference in the commercials that are aired on television and the online ads. But there's still, and I get it, consumers with limited incomes, limited resources, to have those added dollars each month for groceries or utilities is a need. But if we can focus on the critical need, which is their health care and their medical needs, it could hopefully redivert them into plans that are best suited.
And would your recommendation of stronger oversight on utilization of special election periods such as low-income low-income subsidy special enrollment period in the block on enrollments for those with cognitive impairments, would that help if
Yes.
we were to provide more of that oversight in those
Yes, I would
areas?
agree
Okay.
with that. Thank you, Senator.
Thank you. And then, Ms. Hoagland, broker fees. This is an issue for me as well, and it astounds me that this is happening, but I'm not surprised. I am not surprised. Anytime there's an opportunity to make a profit, you're going to see people trying to take advantage of that. I'm very curious, how do the brokers earn these extra incentive payments? And are some of them considered, what we're hearing now, junk fees? I mean, what's going on here?
Yeah, so I would say the add-on fees really do vary significantly, and some, perhaps there could be some value to, an FMO, the middlemen we're talking about. They have some, administrative costs, right, to be set up in an ongoing business. But when we hear things like they're being paid for health risk assessments, we don't see a lot of value in having an agent or a broker complete an HRA for or with a member. That's not something that we can get the data and really use it. And so there are more and more of those types of things where we don't see there being true value. It's just what creative way can we come up with to shift more dollars to incent enrollment in certain plans.
So thank you, and I know my time is up, but Mr. Chairman, I too think we need to address not just the deceptive marketing, but what we're seeing with the broker fees. The goal here is to make sure this is not as complex for seniors so they can access it and keep more money in their pockets and not some other predator who is out there. So thank you.
My colleague, as usual, is way too logical. And heaven forbid, as we talk about these administrative costs, and going back to these Gray Panther days, we always were talking about it. I fail to see how $6 billion in marketing costs in Medicare Advantage is a reasonable allotment for administration. So we're going to work closely with you and look forward to hearing more about your bill. Next in order of appearance would be Senator Langford.
Mr. Chairman, thank you. Thanks to all the witnesses and for your ongoing work and for being here in your preparation today on it. I really do appreciate it. I am, like a lot of other folks, my family's taking care of elderly parents, and MA has been a huge asset to us because it keeps everything all together. We're able to help manage all that and to be able to go through the options on it. So I'm one of many folks that are grateful for it, but also have questions. on how it actually operates and how things actually work. The medical loss ratio piece about this and the gift cards that we've already talked about and such, where that actually gets listed and how plans actually file that as medical expenses gets a little iffy in the process. Are there specific things that you could share that you would say, we can solve some of this by just not allowing the gaming of the system of how they define these gift cards and things and what they apply for, to be able to make sure people are actually focused in on the healthcare side of things rather than on the free cash side of things? Is that a definitional issue that we need to resolve? And I'm fine with anyone who wants to take that on.
I would say I appreciate you pointing out there technically is a limit on what is supposed to be spent for on administrative costs. But I think this is where I'd say that more transparency, to your point, perhaps a better definition on what are administrative costs, what truly are benefit costs, could be very helpful. And then anytime you require that transparency, making sure there are enough audits to verify that folks are completing as intended, and not getting creative with how they complete the forms.
Okay. Any other suggestions on what that definition could or should be?
Thank you for the question. I think about this as really a combination of health and financial expenses. Many people, when they're enrolling in a Medicare plan, do have to make both health and financial trade-offs. And so the question is, how do we make it more transparent to consumers, the all-in cost, the all-in health coverage that they're getting, and whether those dollars come out of Part A or Part B or Part C or Part D with regard to the plan, and which budget allocation I think is secondary to the consumer, but probably very important to the system.
Okay. I want to drill down a little bit more on what Senator Cortez Masto was talking about, the advertising. We've got advertising is one thing, things that are coming in online or on the television. It's another issue when I've got seniors that literally every single day get a call. Day after day, they're getting calls on it. That is, they're furious about it, obviously. But again, this is a business that's trying to be able to reach out to potential customers. We also have that we want to be able to maintain the options and the awareness of it. How do we strike a balance on that? Because my seniors are sick of all the calls coming in on it.
If I may, our seniors are sick of it too. When we are at public events, they approach us afterward with their phone saying, how do I make it stop? And we ask them, they're on the do not call list. That's not enough. And Ohio also is home to, I think, over 250,000 independent agents that want to do right by their consumers. And that's not where these calls are generated from. It's often the lead agencies and these third parties. And I believe if the plans were held accountable for the actions of those middlemen, those entities, it might curb some of those calls.
Okay. What would that accountability look like?
I think punishments for the plans, whether it impacts their star rating on the Medicare tool or financial penalties, that would be determined up above.
Okay. Let me follow up another question on this. Medicare Advantage, and this takes a little bit off topic on this, but the issue with some of my rural hospitals especially, they're getting more and more frustrated with the denials that happen. Just an automatic, it's going to be denied. So trying to get the pre-authorization in process so that they're not going to have denials, or to be able to have a predictability in the process. What we're seeing is literally in my state, we have some hospitals now that just won't take Medicare Advantage, period. They just cut everybody off and said we can't do it because we can't afford the constant chasing for all the denials. So that is exactly the opposite of what we want to be able to create here. What are you hearing on that, and what are alternatives that you would see?
So I appreciate the question. In particular, we serve a very rural population, and our goal is always to partner. I mean, we're part of an integrated health system, so I think that really helps us in thinking about the provider's perspective when it comes to a variety of issues, including prior authorization, as you mentioned. But we spend a lot of time making sure we work closely with our rural facilities. It is absolutely imperative, right, that our seniors can get in for care when they need it, and that we're not putting up unnecessary barriers to necessary care. So this is a priority for us to make sure that we're partnering, particularly in those rural areas where there's not a lot of options, so that our seniors can get in for care when they need it.
Okay, thank you. Mr. Chairman, Ranking Member, thank you for holding the hearing on this, but this is something we've talked about before with if they're on a provider list, but they're actually not a provider that's out there, that's frustrating in many ways. But if you are a provider and you're told that Medicare covers this and you just get an automatic denial for it every time, that also disincentivizes them to be able to be a provider. So I do think we need to work on both sides of this issue as well.
It's an important point. Senator Grassley's next.
My turn?
Yes.
I'm sorry I missed your testimony because I had to be in the Budget Committee also dealing with something with Medicare and Medicaid. I'm going to start with Ms. Regg, a couple questions. I've heard from Iowa independent agents and brokers about the new federal requirements to record all phone calls with seniors and to store the audio files for 10 years. So can you say, is this the most effective way for federal regulators to conduct oversight, and are there more effective ways to ensure quality?
Thank you, Senator. While the SHIPs are impartial and focus on the Medicare beneficiaries, the patients, the caregivers, as a SHIP that sits within insurance, I know that was a struggle for many of the independent agents to take on that added request for recordings. And as shared previously, those typically aren't the bad actors. It's oftentimes large brokers, activity that happens out of state that is consequential for our Medicare beneficiaries ending up in the poor plans. I believe recording the calls from the lead agencies, the third-party marketing, and the out-of-state brokers may have had an impact. I'm unaware of if there have been results or data taken from that. I'm not sure it was effectual with the independent agents.
Another question for you. In addition to the current Medicare open enrollment, Medicare Advantage enrollees can change plans or switch to original Medicare in the first 3 months of the year. This was added in 2016. Currently, this open enrollment is not available for Medicare Part D plans. Iowans have told me that sometimes their Medicare Part D plan pharmacy benefit manager switches the tier placement of a patient's drug during the plan year. This change can increase the patient's out-of-pocket costs. Is this a common problem, and should there be an additional open enrollment period for Medicare Part D?
Yes, SHIPs, I believe, would support that. So we have the open enrollment every fall, October 15th to December 7th. Ideally, in a perfect world, every Medicare beneficiary would accurately review their health and drug options and be in the best plan come the new year. However, we often have to use January, February, and March to review different Medicare Advantage plans, and we don't have that option for the individuals that are currently in original Medicare with a standalone plan.
Ms. Hoagland, Medicare Advantage enrollment continues to grow as a percentage of Medicare enrollment. When I led and passed the 2003 Medicare Modernization Act, 5 million seniors were enrolled in private health plans. Today it's 30 million. Why are seniors choosing to enroll in Medicare Advantage plans compared to the original Medicare?
I appreciate this question. I agree. I mean, I think Medicare Advantage is an undeniable success and offers pretty high quality coverage to a lot of Americans. It is one of the only federal programs that measures and rewards high quality. So I think there's an element of that that beneficiaries can see what plans are considered high quality, and that is something that's an advantage over other programs. It also, I think, can be a very valuable program for rural populations and underserved populations. And so I think that's another reason perhaps why we've seen some of the success. As was noted earlier, definitely the additional benefits are also some things that really do appeal to our seniors and can help with more well-rounded support for all of their needs, not just their medical needs, perhaps some of their social determinants as well.
Yeah. Mr. Blumenfeld, question about PBMs for you. They can have a significant impact on a senior's access to prescription drugs and how much they cost at the counter where they get their drugs. How does your company help seniors navigate challenges created by PBMs so seniors can access a local pharmacy of their choice?
At Chapter, we look at every single Part D plan and every single prescription and every single option of where someone could fill that prescription. That data is unfortunately not available online. The government does not publish it. Insurance carriers do not publish it. Chapter is the only organization in the country where you can actually get accurate information on where to find a prescription at a specific price on a specific Medicare plan. That should not be true. It unfortunately is. So what we do is we look at all of that data and we recommend a plan that minimizes costs given someone's prescriptions and given any potential prescriptions they may need to take throughout the year.
Yeah. And for you and Ms. Reg, this question, what steps have your organizations taken to ensure that rural Americans receive quality and timely information?
There we go. For the SHIP program, we rely on partnerships. Partnerships with the local area agencies on aging, partnerships with faith-based organization, partnerships really with anybody that'll partner with us in those communities to disseminate information timely and accurately to those populations, just as we would those in our metropolitans.
Mr. Blumenfeld.
I think it's really important that we continue to provide more information to consumers so that they can make these really difficult decisions. I think without that and without better regulation oversight over brokers themselves, there won't be much improvement.
Thank you, Mr. Chairman.
I thank my colleague. Next in order of appearance would be Senator Blackburn.
Thank you, Mr. Chairman, and I am so pleased we've got a hearing today on the MA program, and I find it so interesting that for the first time, most Medicare beneficiaries have selected an MA program, and it really has marked a shift, I think, in the thinking of our Medicare enrollees from fee-for-service over to a value-based system. And Ms. Hoagland, I want to come to you first. In your testimony, you talked about MA enrollment growth not being evenly distributed through the marketplace with a concentration in a few national companies. So I want you to drill down on that a little bit about how you see this affecting the overall competitiveness of the MA program and what changes would you suggest we look at as we try to promote competition?
Yeah, so absolutely, this is a huge area of concern. As we talked about earlier, I think competition in Medicare Advantage is what's best. It's what's best for the consumers. It's what's best for the federal government in terms of spend. In particular on this topic, what can we do? I would start with transparency. Transparency in all of the dollars that are flowing over and above that CMS cap, because we do think that's a lot of what is driving the beneficiary choice. It's not necessarily what's in the best interest of the consumer, but where those dollars are flowing. And so I think it would be very interesting to track that data and see, with transparency around total payments, is there a correlation between those dollars and where we see the enrollment lining up? And then the second thing there would be, once we understand and have transparency, to talk about true maximum caps that encompass not just commission but total payments. And so again, then we're making sure that folks aren't using financial incentives, and it's really about placing the beneficiary in the plan that is the best fit for them. And then finally, thinking beyond about, how do we make sure that is directed towards high quality plans and that sort of thing.
Okay, you touched also on some of the aggressive and misleading advertising in the MA space. So a couple of questions there. Can you give us some specific examples on impacts on seniors and what you're seeing there? And secondly, for people that have been enrollees, have you conducted satisfaction surveys to know what they saw as being aggressive and misleading?
Yeah, so one of the things that we do is we watch our disenrollments. We stay right on top of those, and we often will follow up with consumers when we see those come through. And it's fairly often that our seniors weren't even aware they were switched. So that's how aggressive the tactics are, and they're not even understanding. It might be as basic as how would you like to have your groceries covered? And the person says yes, and pretty soon they're switched. That was the key. So they have no idea that the question is leading to them being switched on a plan. We have, as I mentioned in my testimony, a trusted partner who said, ahead of open enrollment, when they're not even supposed to be allowed, their clients receiving 5, 6, 7 calls a day. And so, just the call after call after call, and they're spending a lot of time trying to help re-educate their consumers on, this is what you have, this is why we think it's right for you.
Okay, so it is some of those consumer protection items that you're wanting to see enhanced. Mr. Blumenfeld-Gantz, I do have a question for you, but I'm almost out of time, and I know others want to ask their questions, so let's have you do this one in writing and submit it. I would like to know what you see as the differences between chapter and other Medicare advisors, and then with it being a tech-enabled platform, how do you address the needs of older enrollees and allow them into your program? And with that, I will yield back, Mr. Chairman.
Thank you, Senator Blackburn. Thank you for your question. Senator Menendez.
Thank you, Mr. Chairman. CMS has recently implemented changes to rein in misleading Medicare Advantage marketing practices, yet marketers are finding ways around these requirements. As a matter of fact, the number of complaints that have been filed nearly doubled. A recent Commonwealth Fund survey found that 10% of respondents reported that marketing callers would ask for their Medicare or Social Security number, which is not permitted under Medicare law. Further, while cold calling is specifically prohibited, 3 out of 4 respondents reported receiving unsolicited calls. Ms. Hoagland, what should CMS be considering to step up enforcement and hold bad actors accountable?
Yeah, I think that's a great question, and you're absolutely right that despite some new guidance, and we talked earlier, there has been improvement in some spaces, but we're certainly seeing in many spaces the aggressive tactics really continue. So, I mean, having CMS be in a position to respond quickly as these are reported, I think is really a critical piece, which we believe they are. I just will share, we continue to hear from our broker partners on an ongoing basis that this is an issue. Their clients are getting called. We know sometimes sweepstakes or contests are used as a way to get them in the door. And so folks not even maybe understanding that they've actually have given their information out. And so that's another tactic that we hear that's being used that perhaps could be addressed.
All right. Because this is a potentially vulnerable class.
Yes.
Now, Ms. Reg, is it Reg or Reg? Reg, okay. As you know, state health information and assistance programs, known as SHIPs, are trusted sources of information for many seniors and people living with disabilities. These federally funded resources are tasked with educating and assisting Medicare-eligible individuals through outreach, counseling, training, and specifically support low-income individuals, those with disabilities, and individuals who are dually eligible for Medicare and Medicaid. Given your experience as a program director, how could providing more resources to SHIPs support efforts to protect low-income individuals and those with disabilities?
That would certainly support the added counseling that we've been doing for that particular population. In Ohio, many of our lower income individuals are going through the redetermination, some signing up for Medicare for the first time or enrolling in the low income subsidy, and need extended counseling and assistance to get sometimes into temporary drug programs to curb the high costs. So our counseling for that population is taking longer. In addition, our population has grown, the scope of options and benefits has grown, and we're trying to keep up with that. We're fortunate to have our base grant funds and priority one for MIPA funds, but it's not keeping up with growth. Additional funding could support that.
And I'm troubled by reports that vulnerable individuals, particularly low-income and dually eligible individuals, are being targeted by deceptive marketing tactics and are often enrolled in plans that just simply don't meet their needs. What else can be done specifically to better support these populations and ensure that the care that they need is the one that they get?
For SHIP programs, many of us utilize direct entry into Medicare's complaint tracking module, or CTM. And as I shared earlier, a lot of times we're reactive. They're already in a plan that's not a good choice for them, and we're trying to get them either back or into a plan that is a good choice. If the plans were required to include the agent on record in those complaints, it would help us with the investigatory aspect of it. We're a SHIP, again, that sits within the Department of Insurance. The only regulatory authority that the states have really is on agent activity, and it would help us identify some of the bad actors.
Finally, Mr. Blumenfeld, we know that seniors often find the process of selecting their coverage to be confusing, difficult, overwhelming. I was looking at it now that there's open enrollment, and I'm not sure that even as someone who is pretty well versed in some of this would know how to make the best decisions. Many Medicare beneficiaries rely on a broker to assist them with choosing their coverage. Almost 1 in 3 people ages 65 and over said they use a broker or agent to help them choose Medicare coverage, yet they still often don't end up in plans that are best for them. What do you think consumers should know about making their plan decisions?
First, brokers are not required to put consumers' interests first, and I think that needs to change. We operate differently at Chapter. We do put consumers' interests first, but that is by far the exception and not the norm. So I think it's important for consumers to know what the incentives of their advisors and their trusted guides are. And then I think there's a whole host of data challenges that need to be solved to make sure that the information is available to consumers so that they can make informed choices, because today it's very challenging.
Thank you, Senator. Senator Hassan is next.
Thanks, Senator Bennett. Thanks to the witnesses for being here today. I really appreciate you and your work. Ms. Hoagland, I want to start with a question for you. As we've heard today, Medicare Advantage plans are an important option for individuals on Medicare who are looking for more comprehensive benefits such as prescription drug coverage, vision, hearing, and dental. It's essential that we preserve this option for seniors, but we also need to ensure that plans are fairly and accurately representing their benefits. I have unfortunately heard too many concerns from constituents with Medicare Advantage plans who are unable to afford the medications that their doctors prescribe. While Medicare Advantage plans often advertise comprehensive benefits, many people are not explicitly told, as we're hearing today, by marketing agents that their plans do not include prescription medication benefits. Even for Medicare Advantage plans that do include those benefits, patients sometimes don't get appropriate information about whether or not their medications will be covered or if the coverage will change. So my office recently heard from a constituent in North Conway. She has a Medicare Advantage plan, but it has scaled back her prescription drug coverage. She uses several medications to treat her autoimmune disease, 2 of which were originally covered as preferred Tier 1 drugs under her plan with a low copay. However, the plan partially stopped covering the medications a few months later after she had already signed up, which added to her financial benefit burden. And she previously had a different Medicare Advantage plan that repeatedly denied her coverage for a 3rd medication that she's relied on for more than a decade to manage her autoimmune disease, forcing her to rely on samples provided by her physician. Too often, consumers feel that the Medicare Advantage plans overpromise and then they under-deliver on results. Now, you, Ms. Hoagland, as the CEO of a small health plan with a good record, know what it is to do this well and right. How can we best ensure that these big plans provide the benefits that seniors need? What would you recommend we look at?
Yeah, so I appreciate this question. So certainly, I can't speak to the specific example, but, we've heard stories like this before. I mean, one of the things that we're really committed to is making sure that we maintain a comprehensive and affordable list, and really about working with the individual. to address, right, if there is a change in formulary, but their provider, indicates that this is a necessary drug or there's concerns about side effects for transitioning. We really work with the individual to make sure that they maintain coverage through an exception process. And so, perhaps there could be some more work around how could that exception process work better to make sure that that there's consistency across plans.
Right.
The other thing that we talked about a little earlier is would a large enough change in the prescription benefit perhaps be something that could trigger an option for them to select another plan, because currently that may not be the case.
Got it. Thank you so much. Ms. Regg, I also recently heard from a constituent in Bedford, New Hampshire, who unfortunately has experienced the kinds of marketing practices that we've heard about in the hearing today. This constituent cares for her 26-year-old son who has a developmental disability and is eligible for Medicare. Her son was on traditional Medicare, but a Medicare Advantage marketing agent called his cell phone and got him to agree to switch his insurance. This company took advantage of him during a 5-minute conversation, leaving him with a plan that would not fully cover his health care needs. The good news is that his family found out about it the same day and was able to undo the changes just in time. But unfortunately, there is nothing stopping, as we've heard, this kind of unscrupulous marketing for these plans, and nothing stopping them from targeting the most vulnerable patients who may not have the resources that they need to navigate this kind of conversation. So, Ms. Regg, how can we prevent these kinds of tactics from impacting our most vulnerable populations?
I agree. I'm sorry to hear that story, but it's a story we hear time and time again. We've counseled individuals both under 65 on Medicare due to disabilities and individuals over 65 but with extreme cognitive impairments. And the record that we're able to view on Medicare's system through Marks shows an enrollment almost every month, which is far exceeding what the low-income subsidy special enrollment period allows. So we do file the complaints, and I think, again, knowing who that agent on record would allow us to take a step further in the side of enforcing those rules.
Right. Thank you very much, and thank you, Mr. Chair.
Thank you, Senator Hassan, for your questions. The good news for all of you is I think I'm the last person, but I have a few questions that I wanted to ask Ms. Regg. Let me start with you. Medicare Advantage plans have grown in popularity in recent years. Over 50% of Colorado seniors have selected MA plans over traditional Medicare. While this private insurance provides seniors with more options, we need to provide appropriate oversight and protect seniors from deceptive marketing and properly steward taxpayer dollars, and I think that's why we're all here today. I've heard from hospitals across Colorado, like the San Luis Valley Health, about the challenges they face to get their patients timely care with Medicare Advantage plans. Consistently, hospitals and their patients experience hospital admission denials, delays in care, and plans refusing to pay after they've approved a service. In fact, the head of San Luis Valley Health, Connie Martin, told me that in the past 6 months, the hospital has made 45 hospital admissions requests from MA plans, and every single one of them was denied. This is in stark contrast to a 93% approval number across other private non-Medicare plans. This is utterly unacceptable, and I plan to follow up with the plans directly, I have that plan. We have to follow up with the plans, and she was actually quite specific about who the folks were, and I think we're going to have a conversation. But our seniors deserve better than this. Coloradans with Medicare Advantage consistently tell me that that their surgeries are delayed, often for months, that they were lied to about their level of coverage or that their plan was too expensive, and that their claims are denied when they're told services should have been or would have been covered. All of this demonstrates, I think, that we need greater transparency. And so, Ms. Regg, as a director of a state insurance department, do you have access to Medicare Advantage plan denial rates or approval turnaround times? And if you had access to that data, how would that change your ability to guide seniors toward the plan that is best for them and their health care needs?
Thank you, Senator. At this current time, no, we do not have access to that level of information. Having access to that detailed information and accuracy rate would greatly help us in choosing plans for consumers and allowing them to have confidence and peace of mind when enrolling into those plans.
Thank you for that answer. And I've got a follow-up question for you, Ms. Regg. Coloradans with Medicare Advantage plans often don't recognize that their private plans don't cover their doctors until it's too late. In 2018, the Centers for Medicare and Medicaid Services reviewed 52 Medicare Advantage plan directories and found that over a third of providers were erroneously included, either because the provider did not work at the listed location or because the provider was out of the plan's network. These are often known as ghost networks. Ghost networks make it difficult for a beneficiary to determine if their doctors are in network at all, and this misinformation often leads to unexpected and higher out-of-pocket costs for Colorado seniors. And that's why I've worked with my colleagues, Senator Ron Wyden and Senator Tom Tillis, to introduce the Real Health Providers Act, which will strengthen requirements for these private Medicare Advantage plans to maintain adequate provider directories. It would also ensure seniors do not pay out-of-network costs for appointments with doctors who were inaccurately listed out of network. Ms. Regg, when you help counsel seniors, as I know you do, how important is it for them to know that their current doctors are actually in the network? And do you feel confident telling them that the provider directories they rely on are accurate?
And network information is vital to choosing a plan. As shared earlier, no, we don't rely on the directory or even the plan finder linked to the company's website page. We use that as a springboard for them to work directly with their provider offices to see if they are in specific Medicare Advantage plans. Network information, not just in network versus out of network, but also knowing if there's a prior authorization to utilize specialists, are hurdles that we often go over with Medicare beneficiaries.
I do think, I'm at an end, so I'm not going to ask my third question. I'll submit it for the record. But I appreciate your testimony very much. To me, this is just one more place where seniors are having to spend their golden years fighting just to get the health care that people in other countries, have relied on. And that's when it comes to Medicare, which is something that people generally, I think, feel pretty good about in our country. So thank you. We're going to fix this problem, and I really appreciate your testimony here today. Senator Casey, you're next. I'm going to turn it over to you. Thank you.
Thank you, Senator Bennett. I want to thank the witnesses. I was at another hearing, so we had a conflict, so I didn't hear your testimony, but I'm grateful for your willingness to be here today and to testify about these important issues. Ms. Regg, I'll direct both my questions to you. In your testimony, you mentioned the kind of information and marketing tactics that, quote, often lead to poor enrollment decisions and undesirable outcomes, unquote. Medicare, as we all know, is a promise, and here's the basic promise: guaranteed access, no questions asked, guaranteed access to health care after a lifetime of hard work. Unfortunately, that promise is not often enough fulfilled. Despite this promise, which every member of the United States Senate and House is bound by, despite this promise, we know that many older adults and people with disabilities still have a hard time getting quality coverage because they're either confused by the enrollment process or influenced by misleading marketing, or both. Ensuring that there is both clear information and accurate information about enrollment and different health plans is the very least that government can do so that Medicare-eligible individuals are appropriately educated on how to make the most of their earned health care benefits. That's consistent with keeping the promise. I've introduced the so-called Benny's 2.0 Act, the Beneficiary Enrollment Notification and Eligibility Simplification Act, with Senator Young of Indiana. The bill would provide advance notice to individuals approaching Medicare eligibility, as well as timely information on when to sign up for Medicare. So here's my question. How important is the role of SHIP counselors like yourself in ensuring Medicare beneficiaries can make the best decisions for their needs?
We feel it's vital. We provide objective and unbiased. No one affiliated with the SHIP program can have a financial gain or a conflict of interest in dealing with the information that's going out there. We provide that, and unfortunately, we see the same. Just this month, we were working with a gentleman that was undergoing active cancer treatment, and he got a phone call and enrolled in a different managed care plan that none of his specialists were involved in. And we were able to get him back into his other plan and back on his plan of care.
Well, we appreciate the work that you do. And I'm also concerned about a question that has arisen, I know, in a lot of these discussions, is that SHIPs may not have the resources they need to meet the growing demand due to growing demographic trends and other challenges. Medicare funding to SHIPs and other resources for low-income outreach and enrollment efforts may be in jeopardy because it was not included in the recent continuing resolution. How can you speak to the needs for continued resources for SHIPs given the demands and challenges you're facing and the implications for low-income older adults if funding is not extended this year?
I think it's important to note that the SHIPs are very good stewards of federal funding. The return on investment with both volunteer counselors and the hours that they put in and the dollars saved by enrolling consumers in the most cost-effective plans, signing up for the low-income subsidy or extra help with their prescription drugs, and the influx of assisting consumers with applying for Medicare savings programs far outweighs the dollars that are included in the current grant models. But the growing population, the growing scope, and the demand in every state would warrant the additional dollars.
Well, thanks very much, and thank you for your testimony, and now I'll turn it over to Senator Warren.
All right, thank you, Senator Casey. So this week, millions of people will begin the process of choosing a Medicare plan through open enrollment. And one option is to stay with traditional Medicare. The other is to enroll in one of the many Medicare Advantage plans, or MA, as people often refer to it, which allows these for-profit health insurance companies to offer Medicare coverage. Now, in theory, these private companies should compete on the merits of the coverage they offer. Instead, big MA insurers with a war chest of advertising money use deceptive marketing tactics to lure seniors into the wrong plans. These companies exaggerate benefits. They claim that seniors can keep seeing doctors that are actually out of network, and they deceive seniors about how much they'll spend for out-of-pocket care. This is harmful to seniors, and that's a big part of what this hearing today has been all about. But I want to focus on a different point. It also drowns out competition from smaller insurers, even when they offer a better product. So, Ms. Hoagland, you are the CEO of Security Health Plan. This is a small community-based plan that participates in Medicare Advantage. So can you let's start with, how does your marketing budget compare to the marketing budget, for example, of United Health or Cigna?
Well, I obviously don't know the specifics of what that number might be, but I can tell you it's pennies on the dollar, fractional of what we would have to spend.
So everybody's out there trying to sell their plans to people, and some folks have got huge marketing budgets, and you've got a little sliver of that. So where do these big insurance companies get the budget for all of this advertising? Well, think about the structure here. The government pays MA plans a set amount of money per beneficiary. If a beneficiary is sicker, then the amount of money that the government pays can go up, and then whatever the insurers don't spend on care, they get to keep in profits. Now, as a result of this structure, giant insurance companies have built an entire business around making beneficiaries look as sick as possible by stuffing their medical records with as many diagnosis codes as possible, which means the government pays insurers more money. This is called upcoding, and government watchdogs have uncovered hundreds of billions of dollars in overpayments that result from insurance companies gaming the system like this. Ms. Hoagland, are Medicare Advantage plans permitted to spend the money they make off this upcoding on advertisements?
There's some amount of discretion in how the dollars can be spent. I do want to say I really do appreciate this question and how you framed it, and we would agree with you that we should be competing on the merits of coverage, not on the financial incentives. We certainly believe at Security Health Plan around care, not coding, with care as the focal point.
And I am very glad to hear this, because my understanding is these plans can spend about 15% of the money they get from the federal government, these are your tax dollars at work, on overhead and marketing, and nothing prohibits them from using the payments they get from gaming the system to actually draw more people in so they can keep that practice up. So the way I think of this is the Medicare Advantage plans that game the system get billions of dollars in overpayments. They then turn around and use that money to flood seniors with deceptive ads to lure them to join their plans. But there's one more twist in this. Once people sign up, once the companies make them look as sick as possible, these giant insurance companies refuse to deliver on the care that they actually promised. Now, in 2019, the Health and Human Services Inspector General found that Medicare Advantage insurers improperly denied payment for care in roughly 1 out of 5 claims, leaving seniors with piles of unpaid medical bills. And just 2 months last year, the giant insurance company Cigna used a computer algorithm to instantly deny payment for 300,000 claims, even though trained doctors are supposed to make those determinations. Ms. Hoagland, giant Medicare Advantage insurers are overcharging the government. They are peddling false promises, and then they're turning around and denying care to seniors and people with disabilities. So this is why CMS has taken steps to start to crack down on deceptive marketing and unfair denials of care. Do you think that the government's proposals go far enough?
No, I think there is more opportunity, and again, that's why we're here today. One of the things that we specifically have suggested around the marketing tactics that are currently out there and the additional payments that we see going to FMOs or middlemen is to really require some additional transparency so that it's very clear what all the dollars are and how they're flowing, and understanding who might be the bad actors so that those can be addressed specifically. And then really thinking about, once we understand how the money flows, how do we put true maximum caps on some of these items so that they can't continue to be leveraged for financial gain.
Well, I very much appreciate it and very much appreciate your help in trying to expose these problems today, and appreciate the help from all of you. You know, it's simple. Responsible insurers don't lie and cheat seniors to make a buck, but it's clear that the big Medicare Advantage insurers aren't playing by the same set of rules as some of the smaller insurers. And I appreciate the steps that CMS has already taken, but they need to go further by making the Medicare Advantage insurers publish accurate data on patient care and out-of-pocket costs, and cracking down on practices like upcoding, doing all of this to the full extent of their authority. So thank you all for being with us today. And with that, for the information of the senators, Questions for the record will be due by 5 p.m. on October 25th, and this hearing is adjourned. Thank you.